So our next talk is by Dr. THIRUMALESH. He's a vitreoretinal consultant at Narayan Netralaya, pursuing his PhD by Maastricht University. He'll be speaking on lessons learned from missing macular lesions.
Thank you, Dr. Sneha. So, cataract surgery is a premium surgery because physicians now have set the expectations of the patient so high, and the patient is paying a premium price. So it's very important that one has to look before you leap, before you do a cataract surgery. So this is a case of a 48-year-old microbiologist who came for a cataract surgery, and had we not done a particular OCT, what can happen is that grossly this particular patient was being monitored, and if you don't look at the OCT very clearly, you can see that a foveal lesion like this could be missed. So it's not just important to just have a look at the OCT, but make sure that you take multiple sections. And if you see any problem at the fovea, you address it, explain to the patient that the expectations can be set at the level at what the fovea can provide. So what are the challenges that one would face before doing a refractive surgery, especially now cataract have become or classified into a refractive surgery, is that detect and document the macular disease. Only classic 90-day examination as taught in our post-graduation days will not really help. So OCT becomes a very important investigation. Patients do have high expectations, and technical quality of the procedures and comorbidities have to be told to the patient. This is a very important algorithm. Make sure that you have documented the visual acuity, slit lamp contrast. Along with that, macular test is extremely important. One has to also look at the functions of the optic nerve before you go ahead with cataract surgery and set the expectations of the patient. If the media is too hazy, one can opt to do a Maddox rod OCT VEP. Current generations Webster's OCT can actually document good enough macular structure in spite of the cataract. So what is the role of OCT in cataract evaluation? It's a quick non-invasive procedure. It's an optical biopsy. It gives you a detailed cross-sectional imaging. So the evolution wise, you can see that the time domain OCT which was not very useful in cataracts has now gone forwards, and now we have this web source where you can actually image through very hazy media and get away with it, and tell the patient what's happening. So these are the commonly used protocols. You can do a 3D macular scan, volume scan, or to gain more sections through the fovea, you can do multiple radial raster scan, or you can focus on the areas where there is a pathology and do a line raster scan. So OCT provides this live histology. We all know the layers of the macula, so I'll not delve into that. We all know that these are the hypo and hyperreflective areas. The common pathologies that one should pick up are drusen's, PEDs, ERMs, CNVMs, disciform scars, which all appear hyperreflective on the OCT, and intraretinal fluid or subretinal fluid will appear hyporeflective. So this is a 3D volumetric scan which shows the interface, the retina, and all its layers. One should also look into the average retinal thickness. This gives an insight into what kind of pathology you are dealing with. So when and whom should we image? When vision is not correlating, when patient has complaints of metamorphopsia, when you see that you need to document that there is a condition which is likely to progress, and you want to tell the patient about that. So there are a few pathologies where just observation and counseling is very important. That if you have a solar retinopathy, you are going to tell the patient that they might not really improve beyond a certain level. Patients like dry AMD need to be told that the disease might be progressive. MACTEL patients would end up with CNVM at some stage. Geographic atrophy is definitely progressive. Old vascular lesions might not give a high contrast vision to the patient. However, if you find that the patient has diabetic macular edema or interface disorders or CNVM or polyps, these are the patients who would require combined treatment along with cataract surgery. So let's take a common example of this. A patient of a VMT like this would definitely require cataract with vitrectomy, and these patients would do well after surgery. So these are a few examples where VMTs can definitely, you can counsel for a premium IOL but still get away with it if you do a vitrectomy along with it. So there are certain patients where you set the expectations not very high, because patients with ERM and lamellar macular holes, these are not going to end up in 6.6. So you tell them that although you're going to be better, but you're not going to be 6.5 like you end up in refractive surgeries. So even when there is a hazy media, current generation OCTs can give you a very good detailed evaluation of the macula. So this is a OCT of a patient where you can see that previously there was a laser PDR. So definitely these hyaloid condensations which end up with distortion in vision, the ERM might be responsible. It might not just be the nuclear sclerosis that you're operating for. So it's very important to tell the patient or counsel the patient that they might require a combined surgery to remove these ERMs. Sometimes there might be secondary ERMs which also require treatment. Now, when you see a bad ERM like this, set the expectations of the patient to a certain level that, in spite of a combined surgery, they might not end up with vision beyond 6/18. So there are various stages of macular hole where you can actually give them a prognosis based on, how we end up. PFT is another common lesion where the macula might look very normal. Except for a few hard exudate adjacent to the foveal zone, the patient might appear normal, but these are cases where they are going to end up with low vision as time progresses. If this is the condition, then you would want to tell the patient that they might end up with chronic therapy in spite of cataract surgery. They might require injections as and when it is needed as the disease is progressive. Now, macular edema has multiple associated pathologies. It is not just diabetic macular edema. There can be vascular occlusions, there can be CNVMs, there can be cystoid macular edema. One particular thing is that in spite of a good cataract surgery, patients might end up with this particular complication, which is the pseudophakic CME. So keep a lookout on that. If the patient is complaining of drop in vision in the postoperative period, this might be the common etiological variant. Another condition is myopic foveoschisis, where as time progresses, the schisis kind of becomes more and more, and it can cause decrease in vision. So one should keep the patient informed. So the common treatment would be to remove the hyaloid attachments so that the patient ends up with good vision. So I'll quickly show the study. Yeah. So it's important that one should incorporate macular OCT as a part of your cataract workup. So we did this study where we initially included about 3,000 eyes. What we saw was very surprising, that in spite of an experienced retina specialist examining the patient, about 683 eyes actually had macular pathologies. And macular OCT was very important in picking up these lesions, which amounted to 24%. So in 400 eyes, the pathology was picked up clinically, but a good 300 eyes required an OCT examination to actually pick up these macular lesions. So the most common lesions that were picked up were AMD and ERM, followed by other interface disorders. So there are many other publications which showed similar kind of results. What we did was we updated our study, and currently we had screened about 14,000 eyes, and a good 24.47% of the patients had macular pathology, and treatment altered eyes were about 258. So it predicts visual prognosis. It helps in counseling and educating the patient, and an informed patient will always have a better expectation set, which will lead on to a good doctor-patient relationship. So preoperative OCT in premium IOLs is not just an option. It has to be a part of the examination. It has to be part of the documentation. It has to be part of your counseling, which helps in better outcomes. Thank you.
Thank you, Dr. Thirumalesh. Any questions from the audience?
Dr. Thirumalesh, in your study, the patients who were detected on STOCT were missed by clinically?
Clinically, they appeared normal.
Right.
Many a times, patients who have parafoveal telangiectasia or patients who have early stages of ER, they are commonly missed on the clinical.
Right. So they were detected on STOCT.
Yes. Many times, on clinical examinations, you might find that the patient has an abnormal macula. But once you do the OCT, you just see that it's just a vitreous condensation, which is not altering the foveal architecture. Many times you feel it is normal. On the OCT, they were picked up to have vitromacular tractions.
Right.
So it's important that one does an OCT before going for cataract surgery.
Do you also advise prior to refractive surgery that all patients undergo OCT?
Refractive surgery patients are predominantly younger. OCT, in a way, we don't commonly do. We do a good peripheral screening in those kind of patients.
Right.
But if they have vision which is subnormal, OCT definitely helps.
Or probably history of retinal diseases in the family. So that could be one indication of screening.
Peripheral examination in those would help.
Would help. Okay.
Macular pathologies are not very common until you have subnormal vision in patients with refractive surgery.
Right. Thank you.